Well, I'll just go ahead and kick off the event, and people will continue to trickle in. So, hello, everybody, and welcome. My name is Julie Marie Vanderberg, and I'm the Chief Programs and Products Officer here at PQMD. On behalf of our entire team and our Executive Director, Elizabeth Ashburn, I wanted to welcome you all to today's event. And for anybody who's new to this community, we're so excited that you're here, and we hope that you will take advantage of ongoing engagement opportunities. So PQMD is a global alliance of NGOs and corporates that work together for sustainable access to quality medicines, quality services, and programs around the world, and especially focus on populations in crisis, conflict, or who are difficult to reach. But increasingly, our organization is also working with access to medicines in long-term care and ongoing care situations. So today's topic is incredibly relevant. We're also marking our 25th anniversary this year, and over the past 25 years, and again, just shout out to Conrad for being on the Pillar Talk with us. PQMD was founded by a group of organizations and individuals who care deeply about finding common solutions to finding collaborative solutions to common problems. So our work today spans our pillars, which are humanitarian assistance, health system strengthening, disaster response, knowledge and innovation, climate and health, and of course our guidelines, which are near and dear to our heart. We produce and maintain guidelines for medical product donations, and those are available on our website. We have ongoing programs around the year and lots of ways to engage. So we'll be dropping information about our organization into the chat throughout the event. And as a reminder, this session is being recorded and will be posted on the web afterwards. Please kindly remain muted throughout the program, but you can unmute when you're asking questions. We'd also like you, if you haven't already, to please enter your name and your organization into the chat so everybody can see who's here in the room today. And lastly, but most importantly, want to thank our 25th anniversary Pillar Talk series sponsor, Children International, for making this year's programs possible. We're really very lucky to have members who contribute and invest back into the membership in such dynamic ways. So with that, I wanted to introduce today's moderator. And our session, of course, is Emerging Issues in Global Health for Long-Term Care. So Kate Talinko is a globally recognized expert in health workforce and health systems. She's the founder and CEO of Corvus Healthcare. And Kate brings a world of experience in designing practical solutions to strengthen healthcare systems around the world. Her work spans not only elder care, but workforce strategy and health systems innovation, digital education, and she has experience working with governments, hospitals, NGOs, agencies, and the private sector alike. So Kate, your perspective on the systems that support people who do the work of caregiving and connecting those stakeholders across sectors is invaluable to PQMD and our community. We're really grateful that you're on our board of advisories, our advisory board, and we're thrilled to have you leading today's discussion. So without further ado, Kate, I'd like to turn it to you.
Great. Thanks so much, Julie Marie. Really appreciate it and appreciate everyone for taking the time to be here today. This may be the first time you've heard elder care discussed in a global health context, because usually we're talking about maternal health, child health, sexual health, gender, or other issues that pertain more to younger people and working age adults. And I think the elder issues kind of snuck up on us, but it's become impossible to ignore now. Basically, between 2020 and 2050, the elder population globally will double from 1 billion to 2.1 billion. And also the number of very old, which is defined as 80 and older, will triple. And so this is going to be a huge economic, social, and medical issue for countries. And in fact, it's affecting low and middle incomes even more. They're aging rapidly than high-income countries. And you may wonder why that's happening. The reason is that it's in the low and middle income countries where you're getting that extension of life. So when you look at Europe and North America, people have been living to their 70s and 80s, for the last 20, 30, 40 years. But many countries in the global south, you didn't have people live that long because, diabetes was unmanaged, there wasn't care for cancer, there wasn't a lot of hypertension treatment. And so you're seeing many low income countries which aren't really prepared for their maternal and child health challenges, which are now facing this wave of elder care challenges. And also there, and I think Carol will talk a little bit more about this later on, but there are a number of sort of blind spots around elder care. I've actually been talking about elder care in the Global South for close to 20 years. I published my first paper, I think, around 2006 on it. And as I would go and speak about elder care in the Global South, people would kind of, pat me on the head and say, Kate, it's all right. We're good Indians, we're good Nigerians, we're good Muslims, we're good Christians. We take care of our elders. You don't need to have a formal elder care system in our communities, in our societies. But what has changed, and people really haven't realized, is families are smaller. A person used to have, 7 children, so at least some would be around to care for them. Or, there's more divorce now. And so children are trying to take care of two parents in separate places. Or we see in many countries, most notably in China, the elders are in the rural areas and the young adults are in the urban areas. So there's a geographic distance separating them. Also, women are in the workplace. Women are the traditional elder caregivers, and in many cases, they just can't give that care anymore because they're working and their family is depending on their income. But also, and I think what is perhaps most overlooked, is the complexity of elder care has increased. When you think, what might an elder have needed, 30, 40 years ago, they needed support of activities of daily living. That's bathing, dressing, grooming, feeding, and basic medical administration, giving them their hypertension pill. But now with medical advances, grandma needs sliding scale insulin. So the person taking care of her needs to be numerate, literate, needs to be able to manage complex medical processes, maybe even needs to do home catheterization, take care of chronic wounds. So in the past, when people literally would hire a local village girl to take care of grandma, that's just not an option anymore. The level of care is much higher, and you actually need a formal industry to support it. And we're actually seeing that industry develop in a lot of low and middle income countries. India right now, especially because they have their non-resident Indians, you have millions of highly skilled Indians, working all over the world, sending money back home. Many of them have hired people in the formal sector to either take care of their elders in their homes or in actually residential facilities. I was in Thailand in January and I met with a leader of the elder care industry in Thailand and was surprised to find there are over 2,000 elder care facilities in Thailand. And actually, one of the reasons for this, Thailand as a middle income country is one of the most hyper aged country in the world. And many countries we see they're growing old before they're growing wealthy. And that's a huge challenge. Europe and North America had the luxury of becoming wealthy before we became old. And it's just going to present huge challenges. And one of the ways that Corvus Health has responded to this is by, defining the elder care team. It's not just, elder care workers, it's personal care assistants, it's geriatric nurses, geriatricians, physical therapists. Many people don't realize that one of the biggest benefit you can give to elders with their mobility is regular access to physical therapy. And so that cadre of PTs and PT techs becomes absolutely essential. So Corvus Health has been involved in defining this team and the most cost-effective teams and looking at where they can provide care. And it's important to think about three, locuses of care. The home, and this might be the elder's home or the home of an adult child that they live with, or it could be a day facility, basically like daycare for elders. In the same way you would drop, your 4-year-old off at, 8 a.m. and pick them up at 5:30 or 6. You can have your elder living with you. You feed them dinner and breakfast. They sleep in their own bed, but you drop them off in an elder care facility, from 8 a.m. to 5:30, and they're given enrichment activities, like chair yoga, seated dancing, art therapy, bingo, cards. They're given lunch lunch, their medical needs are taken care of, whether it's as simple as a pill or much more complex. And that is much more affordable than facility-based care, which is often the classic type of care we think of, you know, the long-term facility, or sometimes in the US called a skilled nursing facility. And then also, Corvus Health has designed a globally recognized elder care certificate, because not only do we have a shortage of elder care workers, we have a lack of recognition and a lack of skills portability and mobility. A really interesting story around this is about 2 years ago, Australia hired away about 1/3 of all of Fiji's registered nurses to practice below their license to be elder care workers. So was not only devastating to the Fijian health system, but it was a huge brain waste to have people practicing below their licenses. And when they asked the person responsible for this, like why she had done this, her reply was she couldn't go out and hire elder care workers because that wasn't a thing. They weren't training them. So Corvus Health, by creating a competency-based elder care certificate that meets, all the requirements of major, global North countries and other countries, can enable that facility of movement. And I'm happy to say that this summer, along with El Sheikh's Institute, we're going to be launching the program in the Emirates. And so that's a nice segue to introduce Dr. El Sheikh Badr. I've had the pleasure of knowing him for close to 20 years when we met at the Harvard Health Workforce course. And I'll let Dr. Sheikh introduce himself, and then I'll be asking him some questions about elder care, both in Sudan, where he's originally from, as well as the Emirates and the Gulf, where he's currently working. So El Sheikh.
Thank you. Thank you so much, Kate. Glad to reconnect to you, and thank you so much, Julie Mary and PQMD, for allowing us this opportunity to discuss a very important issue today. And I would like just to start by introducing myself, and then we'll be glad to respond to the questions raised. So I'm Sheikh Badr. I'm currently a professor of public health and community medicine here in Iraq Medical and Health Sciences University in United Arab Emirates. So originally I come from Sudan. I'm a public health physician. I got my qualifications in public health, in medicine and public health from Sudan and the United Kingdom. And I had the opportunity of also attending a number of health workforce development related training in the US, in other parts of the Western countries. My career has been mainly focused on health workforce development issues, and as well health system strengthening. That's why I see myself coming from a policy background and a health system strengthening background. And I worked for quite a long period in the Federal Ministry of Health in Sudan, dealing with policies, strategic planning, and health workforce issues. Then I also worked in professional development and academia, also dealing with training and preparation of the health workforce. I have a short experience with the WHO as well in the regional office in Cairo, in addition to work across the region. So I moved from Sudan to United Arab Emirates, but I'm also engaged in the region-wide movement on health workforce strengthening with the Arab Board of Health Specializations and a number of entities in the region here. Thank you.
Great. Well, El Sheikh, it's a pleasure to have you with us. And so my first question to you is, tell us about the status of elder care in Sudan, how it was before the current civil war and how it is now.
Thank you for that. Looking from a global health perspective or a public health perspective, I think we lived for quite a long period in a time when the population is actually segmented, and the focus was mainly on younger population, I would say, because we see lots of international organizations and governments as well focusing on children, and there is special focus devoted for children, then mothers in the reproductive age, then adolescents, and but little on elderly care, and in particular on long-term care. And I guess I would agree with you, Kate, in your early observation that when we talk about elderly care in developing countries, in countries like Sudan and other developing countries, so first of all, we are talking about a population segment which is not as much as the other segment in terms of the size, because predominantly the demography of our countries is dominated by younger age. This is one thing. The other thing is that the socio-cultural fabrics of the countries, mostly in developing countries, and in particular in the areas where I come from, where predominantly Muslim communities are, families are taking much care of their elderly people, and then nobody would feel that this is an area of priority. However, there are lots of structural changes that we are seeing now globally and in our countries, including Sudan, where the population, as you mentioned, is aging, and we are seeing more and more of improved life expectancy. And then the second issue is that the cultural dimensions are also affected by many factors, including the family size, as you alluded to, but not only that. There are other factors such as women employment and the urban type of changes in our communities. And I think in that context, elderly care is emerging now as an important dimension. But I would say yet to be attended to, because it's still, there is a neglect in developing countries and in our countries on this dimension. And I think the issues around elderly care warranting a long-term care perspective, these issues are not only related to elderly population. Long-term care is currently in our countries also needed in the context of a rising burden of non-communicable diseases. And this is also making it, extending the healthcare beyond facility setting, beyond hospitals, beyond medical centers, to be also addressed at the home level. And we have people living with chronic conditions and people living with disabilities as well. And this is another contextual factor where we are seeing lots of conflicts around us in Sudan, in other countries, in our region here. Conflicts are rising, and the consequences, one of the consequences of conflicts is people who are handicapped and affected by violence. So there are actually increasingly observed changes in our context warranting a careful reconsideration of long-term care and of elderly care as part of this.
Great. Well, thank you. And tell us more about the landscape of elder care in the Gulf and in Emirates.
I actually come from a region which is quite diverse. The Eastern Mediterranean region here involves the majority of the countries in the Middle East here, i.e. the countries of the Arab League are members of this region, but we also have Pakistan, Iran, and Afghanistan as also members in this region. And this region is diverse in terms of the developmental, economical, and socio-cultural context. So we have contrasting environments here. Countries like Sudan, my home country, and a number of developing countries, a number of countries living in difficulty, they have a special context which contrasts with the countries in the Gulf Cooperation Council here, where I'm currently working. So it's interesting to observe this diversity and this contrast. However, what links us as the region, I think elderly care in the whole region is becoming a priority for different reasons. I talked a little bit about Sudan. Now I shift to UAE and the Gulf context, where the population aging is more prominent here because life expectancy has improved much, and we are seeing accelerated growth of the segment of the population that's above 70 years and the elderly in general. That's why the issues around home care, around long-term care, and around primary health care in general are becoming important, despite the fact that our health systems in this region very much focus on hospital care and on clinical care. But the reality on the ground is that we are seeing increasing numbers of elderly and as well increasing numbers of population that are warranting or requesting or requiring continuous care in terms of addressing their chronicity, the chronic conditions, other lifestyle issues. So the demand for long-term care and for elderly care is rising here in the Gulf region because it's really becoming an important and felt priority. And this is reflected in the context of the United Arab Emirates here and the Gulf countries, is reflected by the increasing number of entities and even companies and organizations that are getting involved in arranging this type of care. However, there are lots of issues around this in our region. I think the sector is far from being well organized and is also far from being regulated in terms of how we address the needs of the elderly and we address long-term in general, and in particular home care, in a structured way, in a regulated way. That's why we feel that this area will need a lot of work. And that's, as Kate alluded to, we are starting now to collaborate in this respect. So in summary, the region here has got an evident need in terms of elderly care and elderly health. Despite the diversity in the region, this is now a common priority uniting the region. And I think the urgency here in the Gulf Cooperation Council is clear and evident, where already arrangements around home care and delivery of care by informal sector or even formal health workers being involved informally in this industry is now increasing. And there is quite evident need to regulate it. In other countries, including my home country, Sudan, I think there is lots of momentum that needs to be built around this area because those health systems in countries like Sudan are still living with other pressing priorities in terms of the delivery, the access to healthcare, equity issues, issues around children and women, reproductive health issues. There are lots and myriads of challenges. So one is really afraid that in the midst of these challenges, sometimes elderly care becomes less visible.
Great. Well, thank you so much. And next, we'll move to Carol Agengo of CGSID. Carol, if you could please introduce yourself.
Hi, Kate, and hi, everybody. My name is Carol Agengo. I founded and lead the Center for Global South Initiatives in Development that works on around 4 main issues: equality and justice, population aging and development, civil society engagement, and in advocacy for the rights, the protection and promotion of the rights, particularly of women. I'm a lawyer by training, and I've worked in advocacy over the last 30 or so years, working mainly around the rights of women, but I've also worked on issues of the rights of older people. I was previously the regional director at HelpAge International, which I left last year. So I'm happy to be here. That's a brief of who I am.
Great. Well, thank you so much. And those of you who are not familiar with HelpAge, it's one of the largest NGOs working on elder issues, both globally and especially in the global south. So, Carol, could you please tell us about the current care systems for elders in the global south, and are they fit for purpose?
Thanks, Kate. Allow me to put off my video. I'm currently in Kigoma in Tanzania, and the network is not so strong. So I'll put it off so that I'm able to communicate effectively. Before I speak about the current care systems, I want to just make this introductory remark that when we talk about the care systems for older people, we must look at it from an integrated way, the social, the economic, the cultural perspectives, but also the rights perspective. And this is critical. I'm going to speak particularly about Africa. The global south is quite huge. And so I'll narrow this down to the realities of Africa. The current care systems are such that health, the right to health, is not a guarantee on a general level. So for older people, it's even worse. We've got very poor health infrastructure. We also do not have an adequate number of doctor to patient. The doctor to patient ratio is not as strong as it should be. And so the older people suffer. They're at the tail end of this chain. We currently have 25 geriatrics in Africa. Africa is a huge continent. We only have 25 geriatrics. So that can give you a sense of where we're at. But if you move beyond healthcare, if we look at the social cultural perspectives of care, then these dynamics are shifting. And probably I'll speak to that a little later. But from a policy perspective, the African Union developed the AU policy framework and plan of action on aging. But this has not been implemented because it is not seen as a priority. And so we do not have age-friendly policies or services as a result. And it's because of the weak foundations of care for older people. So maybe I'll pause there and see if you'd like to interrogate further. I have quite a bit to say.
Great. Well, you said a number of interesting things there. One is you said there are 25 geriatricians in Africa.
Yes.
And that's astounding for basically 1 billion people. I'm in Washington, D.C. I'm sure there are 25 geriatricians within 15 miles of where I am. As a physician, I have to say geriatric care is probably the most complex care because you have multiple comorbidities. They're extremely fragile. They don't react to medicines the same way that younger adults do. So it's extremely complex care. And when we talk about age-friendly care, it can be age-friendly on so many different ways. One way it can be, that the nurse or the physician comes to the person's home so they don't have to travel. Or it could be that there's universal access, so someone in a wheelchair or walker can even access the health facility. Then, of course, it could be age-friendly in having health workers that actually have training in geriatrics, whether it's a nurse, a physician, or any other type of providers. I want to dig down a little bit more into the demographics in Africa. Africa really is a continent of demographic contrasts. On one side, it's the youngest continent in the world with a median age of just 19 years compared to Europe's median age of 43. But on the other side, Africa's elderly population is growing faster than any other region in the world. And between 2020 and 2050, the continent's older population is going to triple from 74 million to 235 million. So globally, the elderly population is going to double, but in Africa, it's going to triple in the next 30 years. So could you talk a little bit more about Africa's demographics and the implications for the health sector, in general, and also with implications for elders in specific?
Thanks, Kate. And I will repeat what you've just said about Africa's aging population. But let me start by saying that I am convinced that the framing of Africa as a young continent that will stay young is a political strategy to benefit I don't know who. Because, and I say this because it then impacts the development agenda, it impacts the aid that is received, it impacts a lot of things. And let me speak specifically to that. Currently, average life expectancy in Africa is 64.2 years. Nobody speaks about that. All we hear is 19 years, which is true, but that 19-year-old is growing older. And what happens is that we have fewer children being born. It is a fact that nobody is talking about. We have increased life expectancy, meaning that we will have more older people sooner rather than later. And to repeat what you've said, from the 75 million older people today, by 2050, there will be more than 235 million. Nobody speaks about that. And what happens in the interim? And this currently we have 532 million young people in Africa aged between 15 and 35. Because of the life expectancy that I spoke about, we can safely project that more than 90% of these 532 million will grow into older age. So what are the numbers that we're speaking about? So do the math. And what does this mean in terms of the shifting dynamics? And maybe I'll speak about some of the blind spots that we are completely walking with blinders. The 532 million that will grow older out of the 15 to 35-year-old age bracket. And those in the slightly older ages are not going to grow older in an age-friendly Africa. They're going to grow older in an Africa that is geared towards young people in its psyche, in its infrastructure, in its policies, in its budgeting, and its planning. So we're going to have a problem. The young people, we have a youth bulge currently. We will have an aging bulge in 2050, but we're not ready for it. And this is a blind spot, the blind spots that you had mentioned and which I'll speak to. We look at aging as a linear process. Aging is a multifaceted and complex challenge because we then have to bring the totality of the human being that is aging. Aging does not come at us in a singular form. If there was discrimination against you as a woman, it will walk with you to older age. If there was poverty, it will walk with you to older age. If the policies were lacking, they will walk with you to the older age. And so we must address aging for what it is, as a multifaceted problem. You spoke, when you were responding to the first speaker, you spoke about some of the issues, for example, wheelchair access. We won't even have the capacity to have wheelchair access because Africa, which is currently under construction, if you walk around Africa, it looks like a huge construction site, is being built for a young population. So where will the older people, the buildings are not age-friendly, they're not accessible. The communities that were able to cater to the needs of older people, and these are the shifting demographic dynamics, are now urbanizing. There's rapid urbanization in Africa, and it is not being done with the old aging population in mind. I've already spoken about young people aging. Young people are older people in waiting. They will become old. The two final points on this is that age discrimination is a reality. And if it is not checked now with a small age aging population, it will only get worse when the aging population grows, and we've spoken to those statistics. And then there's a dearth of data on aging. So we are not informing our policies with the realities of the aging population. So, and the data on aging and its impact and consequences. And then finally, the social structure has shifted. When we speak about Africa as a young population, we also have this fairy tale concept around us that in Africa, the way we are socially framed, and I think the first speaker did touch on it, is that we take care of older people. This is changing, and we are no longer taking care of older people, not because Africans have become bad people, but because the social dynamics have changed. Whereas families lived together in communities, this is no longer happening. Like I've said, agricultural land is turning into urban land, into urbanization. So we must think about that. I'll stop there for now, Kate, and see if you have any other questions.
Great. Well, thank you so much, Carol. Really appreciate it. So we turn now to our third speaker, Crispinus Simiyu of Arcadia Homes International. And we're especially delighted to have Crispinus here because he and his team provide direct care to elders in Kenya. So Crispinus, if you could please introduce yourself.
Thank you so much, Dr. Keat. Thank you, PQMD, for having us here on this platform. My name is Crispinus Wafula Simiyu. I come from Kenya. I'm the founder and director of Arcadia Homes International, commonly known in Kenya as Arcadia Homes Care. I've worked with the Kenyan government and local NGOs for over 13 years, where I was prompted now to found Arcadia Homes Care. My training, my background, I'm a public health officer. I've master's degree in public health. I've done quite a number of activities in the community where I founded Arcadia Homes to run and take care of the elderly and NCDs, non-communicable diseases management through home-based care. So that is the work that Arcadia Homes does. We are founded in western part of Kenya, where we normally do home-based care in the rural areas in Kenya.
Well, thank you so much. So if you could tell our audience a bit about what challenges families face when taking care of elders and chronically ill patients at home.
Thank you so much, Dr. Kate. The first two speakers have mentioned quite a number of issues arising from elderly care. And our approach when we look at the families in rural areas, it is a multifaceted area, because these people are passing through not only healthcare challenge, but they're also going through the social challenge and the economical challenge, apart from the cultural challenge too. Just as the former speaker said, people are moving from, especially the young people are moving from the rural to the urban areas, leaving behind the elderly people. And even if they want to take care of them, some of them, because of the cultural backgrounds, they're resistant to leave their ancestral home to migrate, maybe to join their children or their family members who want to take care of them. Then number two, as we are having the increasing number of aging people, then when we look at our healthcare system, especially our hospitals, are majorly designed for acute inpatient care. So if an elderly person is sick, they don't have a room to be admitted in the hospital, because the bed capacity in our hospitals is limited, because our concern in our healthcare system is for acute inpatient care. So for elderly care in our normal healthcare system is not there. So it becomes now a challenge to the families to see how they can manage their elderly. And apparently 90% of the caregivers in our homes are women and girls. So when this issue now arises, some of these people abandon their work. They forego their work to come and nurse their loved ones. It's now becoming a challenge now in the community. Then when you look at our country currently, the unemployment rate is rising so high. So you find a family, they want to take care of their family, but because of the economical challenge, they're not able to sustain their own family then take care of their elderly people. So those are the challenges we are having. So we are having the social challenges. Then we have, on the social challenges still, our program is a holistic program. So we are touching also the WASH program. You find this an elderly person in the house, they can't access even water. So you come this somebody who can relieve himself or herself on his or her beddings. They need somebody to take care, change the beddings, wash the person. And this other person, they cannot even accessing water to the family is becoming a challenge. So the challenges the families are going through are multifaceted. That is economical, healthcare, social, and cultural challenges.
Great, thank you so much, and thanks for that framing of how it's this quadruple challenge. Now, please tell us a little bit more about the type of services that you provide to families and the community.
Thank you so much. Our approach to healthcare in the community is holistic. We are not only bringing healthcare to the patient, or rather to the elderly person or an NCD patient, but we are looking at the patient, we are looking at the caregiver, then we are looking at the community. Because when the patient is affected, the caregiver is equally affected. This is somebody who has left his or her job to come and nurse the patient. When you look at this caregiver, at times they go through burnout, taking care for a long period, 2 years, 3 years, 5 years. Somebody gets tired, they burn out along the way. So they need their psychosocial support. They need caregiver trainings, which you normally do. And then these people, because they have left their work to come and nurse their patients, they are economically straining because age and terminal illnesses, they exhaust people's resources. So these are people who are burnout. They have low esteem. They have low self-esteem. They are here to, they need to provide basic needs for the family. So these people are straining. So when we come in, we are addressing the healthcare issue. We are addressing the caregiver support and ensuring that these people now can, as much as they're meeting the healthcare need, the caregiver need, they're also economically empowered to sustain themselves.
Great, thank you so much. What can governments, donors, and communities do to invest more in long-term care services and elder care services?
Thank you so much, Dr. Kate. I want us to look at elder care as an investment and not as a cost. Because when they look in this perspective, when we support the elder care, we are improving healthier homes. We are restoring the dignity of these people. And we are promoting, there are some admissions and readmissions which we can avoid if we do home-based care. Because we can easily manage some of these conditions while at home. In our organization, we have we have a saying where we say that healthcare is managed at home and it is repaired at the hospital. So if we can manage health at home, then there are some admissions, there are some sicknesses which we can easily avoid. And when we can avoid some sicknesses, then some money which could be spent on these sicknesses, they can be used for an alternative in their families. So it is an opportunity for the government, donors, to invest in home-based care. Because home-based care, you are approaching the issue from a 360 degrees angle. Rather than in the hospital, we are approaching in one direction.
Great. Well, thank you so much. And so now I'm going to open up the questions to some of the questions that our participants have asked. And one of the first I see is asking about faith-based organizations, working in elder care, and especially in Africa. And when I think of faith-based care in Africa, I immediately think of ACHAP, the African Christian Health Association platform. I would recommend reaching out to them. I see actually there's someone from the Catholic Medical Mission Board online. But to our three speakers, are you aware of any faith-based organizations, whether Muslim, Christian, or otherwise, that are providing elder care services in Africa?
Hi, Kate. Sorry, I was trying to unmute. There are lots of faith-based organizations and churches and mosques, Islamic foundations that are providing care for older people. We have a couple of homes in Kenya, in Uganda, and dotted around the continent that are attached primarily to the Catholic Church, but also to the evangelical churches. A lot of them then are operated almost like private entities, and they're not open to the public. We have a lot more of care homes coming up. I've seen a few coming up in Kenya, and I think Chris can attest to that. A lot of them are very small and are niche homes. They cater to a specific group of people. So it's not very wide. It's not as wide as it should be. But yes, the faith-based organizations, churches and mosques are playing a very big role in providing health services, but also care for older people.
Right. Thank you. And another question I see is from Nina Catalano, who asks, are there innovative types of financing that are especially relevant for addressing the unique needs of the elderly in LMICs? And I can think of two for LMICs and one for high-income countries. For high-income countries, there's the reverse mortgage where an elder can continue to live in their home, but get equity, get money from their home to pay for their care. And then the idea is that when they pass away, the organization that bought the mortgage of the house gets the house. So it's a way for elders to unlock the value in their home while continuing to live in their home. And of course, in high-income countries, in some high-income countries, there is long-term care insurance. This industry is fading because it's very financially difficult and people are living longer. So it's just not becoming economically viable anymore. In low and middle income countries, we certainly think first of pensions. I know the World Bank and their social development sectors is doing work with low income governments worldwide on improving pensions for elders. So at least they have a source of income. We know in the U.S., the Social Security system basically eliminated poverty among elders in the U.S. Before Social Security, elders are the group most likely to be poor in the U.S. Now, the poverty is basically solved. And of course, now in the U.S., children are the group most likely to be poor. But also, I think increasingly in low and middle income countries, governments are working to give discounted or free care to elders versus other adults. And so, any of our speakers, are you aware of any special financing mechanism, whether through governments or the private sector, to help elders access care or housing or other supports they might need?
Kate, if I may just come in here and specifically reflecting on our context here in the Eastern Mediterranean region, where we have very conservative family structure and religious intensive communities. I think the family itself is the biggest incubator and the true funder of elderly care. And the burden is mainly shifted on the family. So in terms of providing care for elderly and in terms of also financing the elderly care. So we notice this in our countries. And in terms of NGOs or organizations working on elderly homes, this is not quite seen in our countries. Although in Sudan and in other countries, there are examples, limited examples of these home of these care facilities, which are limited to caring for few numbers of lonely adults or adults who don't have their families around. But for all others, the family is paying the greatest burden of this. That's why, from a policy perspective, we see this is an important area because, as my colleague from Kenya pointed out, there are lots of psychosocial issues, including the burnout, including the price of family members caring for elderly and then leaving their work and sometimes even their family life behind. So this is just a reflection from our region.
Great. No, thank you so much. That's helpful. And I just thought of an additional financing mechanism that I've seen in high income countries. In the US, Medicare will pay for mild home remodeling of elders to keep them in their homes. So, for example, for $5,000, you can install a stair lift and allows someone who has trouble getting up the stairs to continue to live in their home. And $5,000, that doesn't even cover 1 month in a long-term care facility. So just by keeping someone in their home versus having to go to a long-term care facility, it's worth the investment. But I think this question has definitely raised the issue of the need for financing for this type of care. And I see Conrad has another question about do home-based programs build on the existing network of community health workers? And I think this is a challenging question because on one hand, community health workers, are that front line, but on the other hand, we don't want to overburden them with expecting them to provide too many types of specialty care. So I do think community health workers are interacting with elders for general things, like for Ethiopia, WASH is one of their 18 packages. But when you start going into more detailed issues of elder care, such as might be, dementia behavior analysis, prevention and management of chronic urinary tract infections, things like that, it's, I think, too much to expect of a general purpose community health worker. And I know that Ethiopia is looking at creating an NCD community health worker who will have a very different specific set of skills. But Chris, what are your thoughts on engaging, community health workers and other frontline workers, non-nurses, non-physicians in the care of elders?
It's very important to engage them because when we go to the community, we need a community entry point. And some of them, identifying them, we need community health workers. And because this is a continuous care, we do trainings to the caregivers and the community health workers because we need to regularly check their vitals to know how they're doing, their blood pressure, their sugar levels. The community health workers are very important to be in this engagement in the communities.
Thank you so much. And I see there's another question about other determinants of health. We know there are non-medical determinants of health, and in some way that's even more so for the elderly. Whether it's housing, social supports, having a friendship group so they're not isolated. Do any of our three speakers want to talk about the issues of sort of non-medical determinants of health of elders? While they're thinking about that, I'll talk about a program I just heard about yesterday. They followed a group of people who were carriers for the known Alzheimer's dementia gene. This is the gene that is most linked to Alzheimer's, and they had them do a number of interventions, which was a healthy diet, mild exercise every day, socialization, and they found that just doing those things dramatically decreased their likelihood of having dementia symptoms. None of these things are medical. It's eating properly, movement, and socialization. But do either of our three speakers want to speak about the non-medical determinants of health for elders?
The non-health determinants are very many to the elderly people because in such countries in Africa, we can start from the way Carol was talking about even movement, accessing some of these assistive devices like wheelchairs even a commode, a normal thing like a commode, it's very difficult for them to access it. Even just like accessing diapers daily for them to change, it's quite hard for them. And Maki, some of them are on terminal illnesses. So we need a nutritionist to give them a certain type of meals for them to get. And now maybe even the caregivers, they don't know how to prepare such meals. And at times now, all the caregivers and the household are forced to eat what the patient is eating. If it's the food without salt, without sugar, without milk, they're supposed to do, because even for them accessing a variety of meals becomes a challenge. So apart from the medical, there are so many other things. You come and look even at the housing, maybe the beddings where these people are sleeping. Maybe they don't have even beddings. They're using even like old clothes for them where they're sleeping. So apart from the medical care, there's so many other things, components which come in.
Oh, that's great. Yeah, and also, there are groups such as Wheelchair International. I think there's Mobility International that work on getting, fit for purpose, affordable wheelchairs and other mobility devices to people. And then as another question, perhaps our final question, how would you suggest that PQMD members can help elders in both low and middle income countries, also in the Gulf? How can they access these markets? We know that these are growing markets. There's a high demand for medical consumables, whether adult diapers that was mentioned or assisted devices, devices to help move people. So what are your thoughts on how the members can get engaged?
Yes, if I may come in here, and I think there are opportunities now for partnership around this topic. In our region here, this issue is now being highlighted, is becoming as an emerging priority, and that's why in our center here, the Center for Health Workforce Development, we established a program around long-term care and the policies for long-term care. And Kate is already starting to partner with us. So in terms of PQMD and other colleagues and other entities, I'm here also extending this invitation to partner. We are looking at the issue here in the region from different perspectives. From a policy perspective, we are also taking it from a health system perspective, trying to sensitize our health systems to prioritize long-term care and elderly care. And this is actually working towards a shift in health policy in our countries. And I think it's high time to do so. We are also taking it from a workforce perspective in terms of the capacity building of the workforce, either the existing health workforce or even the caregivers at the level of the community and home, and how to equip them. And to that end, we are collaborating with Kate now on a standardized training in this respect for home care givers and caregivers in general, because currently they are acting in this domain without adequate preparation and adequate training. The third dimension is research, where we are also starting to conduct research into this area with full engagement of the community, because it will not be possible to fully understand the dynamics around long-term care and elderly care, and in particular, the family dynamics and the social dynamics. These cannot be understood unless we do research and studies on them. That's why we are focusing on this. And last but not least, we are extending collaboration beyond the health sector. So we are reaching out to the social sector in our countries here to get involved and to partner and to pool resources to try and standardize long-term care, including elderly care, and then act accordingly. Thank you.
Great. Thank you so much. Thank you to Dr. El-Sheikh, Carol, and Chris. You can reach out to us. We're all on LinkedIn. And now I'd like to hand it over to Julie Marie.
Yes, thank you so much, everybody. Really lovely, fantastic conversation, incredible insights, and some very important overlaps with the work that everybody on the call is doing. really appreciate your time and your being a part of this community. Thank you, Carol, Chris Venus, and Dr. Elsheikh and Kate. And we also wanted to put up a quick survey before you guys go. Please respond to the really quick questions that will help us to shape the programs so they're more relevant for the work that you're doing every day. And last but not least, I wanted to make sure that we made you aware of our Global Health Development Essentials course. We'll be running the next cohort starting in July 8th. And we'd love for anybody to join us who's interested in a survey. It's like a mini MPH boot camp survey course that will help orient people to global health work, and also includes this incredible community. So your cohort would be full of cross-sector participants that you'd be able to network and collaborate with. So thank you very much for joining us today, and have a wonderful day.
Thank you, everyone.
Thank you.
Take care.
Thanks,
Have a wonderful
Kate.
day.
Bye, everyone.
Thank you.
Thank you.